So in this video, we're going to talk about how we're going to manage your pain post-operatively. So at each visit, I want you to bring your book so that on the inside, we have a pre-flight checklist, I call it. I can go over the medications that are going to be specific for you so that you and your family, as well as any of the nurses and physicians and assistants taking care of you during your surgical procedure, know what the plan is. So make sure you bring your book, and we're going to go over that in our office. So I'm going to talk a little bit about what the options are. The first thing we need to consider is that every knee or hip replacement has the potential for blood clot. So we generally use a medication to help reduce that risk. Now everyone knows to follow my two simple exercises: the walking once an hour, a short walk, 10 feet, 15 feet, that's all you need, and then some ankle pumps. And then you can do as many per hour as you want, but at least 10. Those two things help reduce blood clot risk. But in general, we also want to use some sort of medication to help reduce risk. The one I use most commonly is baby aspirin. We use that for patients with no history of ulcer and no kidney disease, and of course no allergy. It's equally effective as all of the other more stronger medications on the market, but also has a little less infection risk. So overall, I try to use that for most patients. But we can use other things like Coumadin, Xarelto, Eliquis. Those are things you may have heard of on TV. And these are things that are short, we use for a short duration, not for a long time. If you're already on one of those medications, then I will discuss it with you, and we will talk about how we will use that medication or not. So make sure you bring that to my attention. We then use several different medicines to help with pain. The first medicine is something everyone's heard of. It's called acetaminophen, also known as Tylenol. That's one of the brand names. That medicine we use 3 times a day, so it's not full dose, but it's pretty close, 75%. And that can help reduce pain. Multiple studies showing that it works. So even if you're one of those people who say, "Doc, Tylenol, acetaminophen never works for me," I want you to use it. And again, we will discuss it and make sure in the office. We also typically use a non-steroidal. So many people are familiar with those medicines such as ibuprofen or naproxen. The negative to those is that they affect the platelets and make you bleed a little more. So I generally use things like celecoxib, also called Celebrex, or meloxicam, also called Mobic. And again, these are written inside the cover if you want to look them up. So most patients will use one of those. It helps with achiness, it helps with pain. And then we typically use some low-dose prednisone, 5 milligrams, so not enough to make your cheeks blow up or gain weight, but it can help with the achiness and the swelling. And swelling is the thing that causes the most pain, so we really want to work on controlling that swelling. So in general, those are the 4 medicines most patients use that are all non-narcotic. We then have one other medicine that's non-narcotic that we frequently can consider, and that's something called Gabapentin. It's been around for many years. We use it for diabetic neuropathy, burning in the feet. We use it for sciatic pain, burning down the leg. Or after surgery, you can get some burning and discomfort along the inside of the knee particularly. So I tell many patients, you know, my wife has cancer treatment history, and she had terrible burning in her arm after surgery, and the narcotic didn't help at all. And so we used Gabapentin, and it made the burning 80% better, and it made a dramatic improvement. But it does have some side effects. It can make you sleepy or a little forgetful. So after 5 days, she said, you know, my burning is much better at my arm, but it makes me too sleepy, so I'm only going to use it at night because it helps me get to sleep. So a lot of patients will also use it for sleep. So you can use it for burning, you can use it for sleep. Lastly, some patients find that it does help with pain, just regular pain, and we use it for dogs and cats, horses, I believe. So again, it's being used for pain as well. So it's the next pill you can try that's non-narcotic. It does have a little side effect profile, but we may discuss that in the office. The last option is a narcotic. Narcotics can help with pain, but as you know, they have side effects: constipation, nausea, hallucinations, dry mouth, difficulty urinating or peeing. And so you want to use those sparingly. So I generally tell patients, consider the 2 options: either something like Tramadol, the mildest one that we have, or something stronger like oxycodone. And again, the stronger pill may help the pain better, but also may have more addiction risk, more side effect risk. So you have to, we'll weigh that here in the office together. So As we talk about those pain medications, I'm now going to speak specifically about knee replacement. Knee replacement has 3 typical spikes that most patients complain about pain. It happens around 36 to 48 hours when the knee swells. We have all sprained our ankle, and the day that you sprain it, it's not so bad, but boy, 36, 48 hours later, you can barely walk on it, right? So I think most of us have had that experience. Same thing happens after knee replacement. The knee gets big and swollen around 36 to 48 hours, and holy cow, it really hurts. So I tell patients, they're already using certain medicines kind of around the clock, the Tylenol and so forth. That's where we might need to turn that pain ball up. That's talked about in a separate video. Currently we're using a pain ball. You may need to turn that up to help reduce pain. You may need to back off on your exercises for an hour or two to reduce that pain and get over the hump. Or you may need to ice it, or maybe take a Gabapentin. 30 minutes later, still no better, turn that pain ball up. Maybe even at that point take one of those pain pills, the narcotic pills. The biggest key for us with narcotics that you need to be aware of is that there is if you use it around the clock for 24 hours, there's a 6% chance of becoming permanently addicted. So I'm not saying to be completely scared and don't use it at all, but I'm also saying be cautious with it. I don't want any of my patients to get hooked on medicines that they need for the rest of their life. The next period of time that causes discomfort is generally when the pain ball wears off, between 3 and 5 days. There's about a 6-hour window where patients will say, oh my gosh, I guess that pain ball really was working. And so they take it out. They have to ice it. Again, maybe back off on the exercises for an hour or two. And then if the Gabapentin doesn't help, again, maybe use a pain pill. The third time that the pain spikes typically is somewhere between 7 and 10 days for a knee replacement patient. For whatever reason, the swelling starts to shift down the leg, and again, for some reason, certain patients, maybe 8 to 10% of patients, will have increased pain between day 7 and 10, maybe day 8, somewhere in there. And again, you may need to back off on the exercises, use a Gabapentin. That's not working, use a pain pill. So on average, we see patients using 1 pain pill each of those 3 periods if they're one of the people who have that increased pain spike.